Well, welcome everybody to this hour-long webinar entitled Current Management of Brain Metastases, in conversation with a wonderful patient, Kris Hallenga, Dr. Michael Kosmin, my colleague in oncology, and myself, Neil Kitchen. Now, we have many registrants today, both doctors and patients and other stakeholders, both from the UK and abroad. And we welcome you to submit questions throughout the webinar via your chat box. And we want to reassure you that these are totally anonymous and also private. And then after our talks, we will go through some of the questions as we're able to do in the time allotted to us, but we must finish in 1 hour. So first of all, I'm going to give a brief talk on metastases and the treatment option of SRS. And then Kris is going to discuss matters personal to her. And then Michael will talk about some technical capabilities to do with Gamma Knife. So let's make a start. Could I have my slides, please? So first of all, some history. Gamma Knife radiosurgery was started and invented essentially by Lars Leksell. He invented his frame in 1949, but he defined stereotactic radiosurgery as a technique for the non-invasive destruction of intracranial tissues or lesions that may be inaccessible or unsuitable for open surgery. The Gamma Knife itself came into being in 1967 and utilized the cross-firing principle, multiple simultaneous narrow beams of gamma radiation emitted by a radioisotope. And the more fields one used, the steeper the fall off we see here. So in fact, this technology has been around for over 50 years. And in that time, there's been an evolution in both the hardware in terms of the apparatus, but also the software driving the machine. And so this is the current model which we and others use. It's called the Gamma Knife Icon. And this allows us to do Gamma Knife radiosurgery, mostly as a day case procedure performed under local anesthetic. And broadly speaking, one can divide the day into, firstly, what the patient remembers most of all is frame fixation. Secondly, imaging using MRI and sometimes angiography. And thirdly, the planning of the treatment. And finally, treatment delivery. The treatment itself is painless and silent, unlike the MRI scanner. The duration depends on the number and shape of the targets and dose, etc. Breaks are possible in the treatment, after which there's a 30 to 60 minute recovery before discharge, and there's really no significant restrictions in the days after surgery. Now with the Icon, traditional frame-based treatments you see on the left are possible as usual, but also mask-based treatments as you can see on the right. And the mask offers for some patients more comfort, though can be claustrophobic if having to be used for a longer period of time. And they also have the possibility of allowing for a bit more movement than the rigid frame. And so if the mask is used, we have a real-time tracking camera so that we can reassure ourselves that there's no excess movement, reducing accuracy. A further recent development has been a new frame. The frame in the previous slide was the traditional G frame made of metal. This new Vantage frame is essentially made of fiberglass and gives us a much more accurate and clear imaging, but in addition, the patients find more open and less claustrophobic. And this is a picture of our first patient, and we've just started using this frame. Now, what does the gamma knife treat? Well, a lot of benign conditions in the brain, tumours, vascular abnormalities, and functional disorders. But this evening, we're talking about the treatment of brain metastases. These are malignant tumours that have spread from primary cancers elsewhere in the body. And if you look at our gamma knife over the last decade since it was installed, there's been a steady growth of all indications, but the pink here is the percentage of cases of metastases, which in 2017 was 27%, and indeed in 2021 was over 35%. So it's a growing indication in our practice and amongst most gamma knife centres worldwide. Why is this? Well, brain metastases are becoming more common and presenting earlier as patients with primary cancers are living longer with improved treatments. Gamma knife SRS has become a well-established treatment for brain metastases and in many countries has largely superseded whole brain radiotherapy. The NHS in England allows repeated SRS treatments of the same metastasis, if necessary, and also if others appear, as well as staged treatments for larger lesions. And this is perhaps in relevance here that this may be where the mask head fixation may be most useful. And there is now an established network of NHS England approved SRS centres in England, using either the gamma knife or other radiosurgical platforms. There are some criteria from NHS England to allow one to treat patients with brain metastases, and these can be boiled down to the following. Patients have to have controlled or controllable systemic disease. They have to have a KPS, that's a performance status over 70, which is essentially someone who is independent in and outside of the home. They have to have a life expectancy of over 6 months. And importantly, the total volume of the intracranial metastases has to be less than 20 cc's. You can see from these criteria that there is some wiggle room here, apart from the last one. Now, in our patient population of brain metastases treated with the gamma knife, the commonest primary cancer is lung, 39%, and then breast, 27%, with melanoma at 20%. And in terms of the number of metastases we treat, single metastases in 34%, 2 to 4 metastases in 44%, and over 5 and over in 22%. The average metastases we treat per procedure has been 4 in this particular cohort of patients. And Michael is going to talk later about various responses, but this is just to show you not how good the treatment is necessarily, but how quick the response rate is. So with the benign tumours, it can take years, in fact, for any response seen on imaging. But with malignant disease, we see reduction in size, as you can see here in these examples, can occur within just a few weeks or months. In our first cohort of patients we studied, our overall rate of control for each treated metastasis, that is to say the prevention of growth, was essentially 95%. So we know it's a very good treatment of controlling local disease. And this compared very favourably with colleagues elsewhere in the world with earlier series given here. Well, what about overall survival? Well, this is an example of a paper from Japan looking at the number of metastases treated. it was said in the past that multiple metastases meant much poorer prognosis. Well, the green graph line here is patients with one brain metastasis treated, a single one. And then the red and the blue lines are those between 2 and 4 tumours and those over 4 tumours. And there was found to be no difference in survival between these two groups. There was, however, significant difference in the total volume of brain metastases. So you can see here in the red, the patients have a poorer prognosis than those in the blue, where the estimated median survival could be almost 28 months. And this really marries with what the NHS England criteria is of limiting the volume of total brain metastatic disease. The other reason for differentiating survival in patients treated with gamma knife in these circumstances is the primary cancer. And here you see a paper looking at melanoma in yellow, breast in green, and lung in blue. Having said this, this is really oversimplified, because we can split up melanoma into those which are BRAF positive and BRAF negative, and those in lung who have actionable mutations or not. So it has become much more complicated in the last several years trying to prognosticate the utility of this treatment modality. So what we can say, however, is that gamma knife is highly conformal, i.e. treats just the tumours we tell it to treat, a minimal amount of radiation to the surrounding brain. So it protects normal brain because it has a high geometric accuracy and because it has a steep fall off into the surrounding brain. And it does allow us to fractionate or stage or adapt treatments with the frame or the mask. The increase in numbers of patients treated in the gamma knives around the world with brain metastases is associated with their improved overall survival. We know that it has very good local tumour control. And as I've said, it's the volume of metastases, but not the number of metastases, which is a predictor of the efficacy of the treatment. Finally, I wanted to point out that it is the multidisciplinary team which we feel is the most important structure in helping patients with multiple brain metastases. Radiosurgery, radiotherapy, surgery, and systemic therapies are often used highly effectively in combination in patients with metastatic brain tumours. So a team approach to patient care is absolutely vital. Immunotherapy in melanoma, actionable mutations in lung cancers, or post-surgery gamma knife are all examples where this interplay of treatment occurs. And we have found that repeated SRS treatments in our metastatic patients spread over many months and indeed years is becoming commonplace as a result. So thank you for your attention. And I hope you're putting in questions, as I've indicated at the beginning. And now I'd like to introduce Kris Hallenga, fabulous person and a patient advocate for all those with cancer. And I hand you over to her for her personal observations. Thank you, Kris.
Thank you. Hi, everyone. Thanks so much for joining us this evening. So I'm here to give the patient perspective on everything that Mr. Kitchen just talked about. I'm going to use a lot less fancy words and bring it back to the patient, the patient, and what the patient experiences throughout gamma knife radiotherapy. So in order to do that, I need to rewind to 2009 when I was diagnosed with breast cancer at the age of 23. I had for a long time been told that the symptoms I was apparently there's issues with sound. I hope that you guys can hear me okay. I'm going to continue anyway until someone else tells me to stop. So in 2009, I had been repeatedly told that the symptoms I was experiencing were probably hormonal changes, because I was a young woman and they might have been connected to my hormonal monthly changes. And then it took a third visit to, okay, you guys can hear me, great. It took a third visit to the GP to finally get a diagnosis of breast cancer. And this was after 8 months. So between 8 months is when I first went to the GP, and then finally told that it was breast cancer. And because I had been experiencing some other changes, some other pains in my back, some other tests were performed to see whether the cancer had already metastasized, and it had. So I was diagnosed with stage 4 from the get-go, otherwise known as secondary breast cancer, as it had already spread to my spine. Obviously deeming it incurable, but still treatable, and obviously very treatable considering that I'm still here 13 years later. So initially I started with some chemotherapy to try and shrink the tumor in my breast before they could operate and take it away. And I went on to have some radiotherapy to treat the tumor on my spine, as it was causing me quite a lot of pain. So this was kind of treated as a more palliative treatment to try and ease some of the symptoms I was experiencing. The chemotherapy did its job and I had a mastectomy. I went on to take some hormone therapy because my cancer was hormone positive. Within 2 years, the cancer spread to my spine, to my liver and other areas of my spine and my pelvis and my hips. So that was in 2011 that I got that diagnosis. Only one of the areas was symptomatic. The rest was picked up on regular 3 monthly scans. And the liver tumor at that point was really small. We altered my hormone treatment, and within 1 year, the cancer then spread to the brain. So in 2012 was when I discovered my very first brain tumor. And again, this was picked up with a routine scan. I have to say that I think there's sometimes an issue with people being checked from the neck on upwards. If you've had breast cancer, you're not always routinely given brain scans. Luckily, I pushed for one. I had some headaches, but I'm a very headachy person. So we weren't really sure if it was a symptom of a new metastasis or whether it was just my migraines. But we did a scan just to be sure. And that's when they picked up a tiny lesion in my brain. And at the time, we treated it with stereotactic radiotherapy, so very targeted radiotherapy, a bit like hammer knife, to treat just that one lesion. And I only needed one treatment for that. And it did very well, responded very well. And after that, I was monitored again. Again, we didn't drastically change my systemic treatment because my cancer was still looking like it was hormone positive. We treated it with other hormone drugs. And then in 2014, we discovered another tiny lesion in my brain in a different spot. The previously treated one had remained treated, hadn't grown, hadn't regrown. And so we treated the newly found one with the same type of treatment with stereotactic radiotherapy. Everything was going okay after that. And again, I should say that that was picked up from a routine scan again, not symptomatic whatsoever. These are tiny lesions which shouldn't really have given any symptoms anyway. In 2015, 2016, yes, I have to remind myself of the time frame because it's been such a long time. But in 2016, we did extra things like remove my ovaries to help stop the cancer from progressing anymore. And then at the beginning of 2018, so we are talking 4 years ago now, again, a routine scan showed that I had somehow managed to sprout multiple brain lesions. At this stage, I had changed my treatment from a London hospital to a Cornwall hospital. And at this Cornwall hospital, at Royal Cornwall, they weren't able to offer me targeted radiotherapy. And so I was referred to another county hospital in Devon, who looked at my scans, and on reviewing the scans decided that there were too many tumors to treat with their very targeted radiotherapy machines, and that they had a cutoff point. They reckoned there were about roughly 11 tumors that they could see, and their cutoff point was 10. So they had a rule where it was the number of tumors that they would treat, not the volume. And obviously I had to learn these things very, very quickly. So I was referred back to my original hospital, where they told me that the only treatment option that they had there, given it was their trust in Cornwall, was to give me whole brain radiotherapy, which some of you are probably more than aware of what it is, but essentially, as the name suggests, treats your whole brain, leaving all the good and the bad bits of your brain treated. I thought that was rather drastic, given, again, I was asymptomatic. On some of the letters that I was reading from my clinicians, there was this score that I read on this piece of paper that said that I had a performance score of 0. And I had no idea what that meant, but having Googled it, it means that I function like any old other person walking down the street. I am perfectly capable of looking after myself, and it didn't affect my day-to-day life. And so I thought, if it's not affecting my day-to-day life, which is a fact, and I wasn't having any symptoms from all these tiny little tumors, surely it would be like hitting a walnut with a sledgehammer, giving me whole brain radiotherapy. And given that I'd had very targeted radiotherapy in the past, I thought there had to be a way to get that same kind of treatment again, which is when I then had to go and off on my own exploration to try and find a hospital, which ended up being UCLH, to find someone who would treat the tumors in a more targeted way. And that is when I discovered gamma knife radiotherapy. And that is when I finally got to sit in a room with Mr. Kitchen and Dr. Naomi first, who said, we can treat this because we have a rule that it's not the amount of tumors, it's the volume that we look at. And by the looks of it, these tumors are all very small. And so we can treat this with gamma knife radiotherapy, which I was obviously so incredibly relieved about. And so in 2018, I ended up having 3 lots of gamma knife radiotherapy. So in that first round, I think we ended up treating about 15 tumors. I got to wear that metal mask that you just saw in that presentation, which was not a pleasant thing to be placed on my head. I think that's probably the worst bit of the treatment. They were all treated beautifully. They responded really, really well. They stopped growing. And then 3 or 4 months later, on another scan to check how they were doing, we discovered, yes, they were treated well, but I'd managed to grow new ones. So we repeated the treatment on these brand new ones. Within 3 or 4 months, it was the same news again, and I had to have another bout of treatment. Overall, I mean, I must have spent around 20 or so hours in total in that machine getting this treatment. I won't sugarcoat it. It's not a nice experience because it can be incredibly claustrophobic, lying in a tube for so many hours. Obviously, the team make it as pain-free and wonderful and calming experience as possible, but nothing can really ever prepare you for something like that because it's so unnatural. So obviously, even though the treatment was working very beautifully, what I needed was a new systemic treatment. And that's when, in collaboration with my oncologist and the rest of the team, a bit like Mr. Kitchen just mentioned, a multidisciplinary team was looking at this from every angle. And we decided that I needed a new systemic treatment, which was a new chemotherapy, oral chemotherapy, which I then ended up taking. And that was 4 years ago. And I haven't had a single new brain lesion since. So in 2018, roughly, we treated over 50 tiny brain lesions. And I think you're going to get to see some pretty pictures of that shortly. And thankfully, with the systemic treatment that I went on to, there haven't been any new ones since. But I will caveat that and say I'm waiting for some brain scan results at the moment. But I'm feeling really well. I've now recently had to change to a new chemotherapy oral drug because the previous one had stopped working. My liver lesions have progressed. So we've had to target that with a new treatment. And that's definitely making me feel worse than the one that I was on before. But on the whole, pretty good. So that's a whistle-stop tour of what's happened to me with my brain mets. I hope that's helpful. And obviously, any questions, pop them in the chat. I'm happy to answer stuff, and I'll check to see what's happening now. But yes, welcome back.
Thanks very much. Thank you very much, Kris. That's incredibly valuable for everybody. So we're going to move swiftly on to Dr. Michael Kosmin now, and Michael's going to talk about SRS from the oncologist's, not the surgeon's, point of view. Michael.
Thanks, Neil, and thanks, Kris, for giving such a clear talk and giving us all a much clearer understanding of what it's like to be diagnosed with brain metastasis, what it's like to have treatments, what it's like to fight for your own treatments to make sure you get the best outcomes possible. So I'm just going to spend a few minutes going through a few cases, which I think highlight some of the technical capabilities of gamma knife radiosurgery. I'm a consultant clinical oncologist, so I'm a neuro-oncologist treating primary and secondary brain cancers, and I work with Neil in our multidisciplinary gamma knife team. So I'm going to go through kind of 3 different cases, essentially, just to highlight some key aspects to the capabilities of gamma knife and what it's able to do, and show you perhaps some cases that stretch the boundaries a little bit of what we would think of as routine treatments, both in terms of the volume of disease, the size of the tumors, and as Kris has alluded to, hers is a particularly great example of gamma knife giving good outcomes from multiple small brain metastases. And I think this is the platform which certainly does that better than any other. So we'll start off with a case. This is a patient who's 36 years old, was diagnosed almost 2 years ago now with HER2 positive breast cancer, and underwent a multidisciplinary kind of breast cancer management, as you'd expect based on the staging at the time. So underwent curative treatment with neoadjuvant chemotherapy, followed by mastectomy and axillary node clearance, which then itself was followed by radiotherapy to the chest wall and to the locoregional lymph nodes. And then the patient continued on with systemic HER2 targeted therapy. So a complicated but well-established kind of multi-treatment pathway for breast cancer patients. But then unfortunately, the patient presented with seizures, absent seizures, when she was down visiting the south coast of England in Brighton, and that was last October. And so she was admitted to the hospital in Brighton and underwent an MRI scan at the time. And just like Kris has described, this is a young lady, performance status 0, meaning completely normal day-to-day function. And from the perspective of her, the rest of her breast cancer disease, her extracranial disease, her prognosis was clearly expected to be well over a year. So this was the imaging that was done at the time of her presentation, in fact, at the time of her gamma knife treatment, which followed very soon after. And you can see from this T1 weighted image with gadolinium enhancement that there are multiple enhancing metastases that you can see, primarily cortically based, but also some more central lesions. And this is just 3 images of the scan. You can see that individually, these aren't particularly small lesions. These are rather large in size. And when it came to going through the scan in more detail, there were in fact a total of 9 metastases that were present, which varied in volume individually from 0.3 cc's to 2.5 cc's being the largest. And the total volume of disease for this patient was 11.4 cc's. And so there's a point to make here about the fact that we have 9 relatively large looking metastases on a scan, and the total volume is 11 cc's, quite a long way short of the cutoff of 20 cc's that Mr. Kitchen mentioned in his talk earlier. So this patient underwent gamma knife treatment to these 9 different targets to a dose of 20 or 22 gray, depending on the size. And that treatment took place in November of last year. And when we treat patients on the gamma knife, we do an early follow-up MRI scan, usually approximately 6 weeks after the treatment, to get an early idea of response and to ensure that there's no new sites of disease that have developed. So between the 11th of November and the 23rd of December last year, the lesions that we saw here significantly responded to the point where we're struggling to see residual disease. So an almost complete radiological response, even within such a short time frame. So you can see the image here, and overlaid on top of that image are the original targets from the gamma knife treatment. An excellent initial response. And here we go. This is another example of a lesion that was treated. So again, this was the lesion treated on the day. This is the planning MRI scan performed on the day. And 6 weeks later, it has really significantly reduced in size. And there's kind of this small area of diffuse enhancement that remains. So a very good response for the patient, and clearly very good news. So the next case is one that you have just heard about, and I'm not going to go through the history because it's far better you've heard it from Kris herself. But as she said, she was offered whole brain radiotherapy, but then went and sought out the alternative focal treatment of gamma knife for her metastatic disease. And as Kris has said, she had 3 separate gamma knife treatments throughout 2018. Initially in January, where 15 metastases were treated. And then again in July, in the summer, with 23 mets treated, and a further 21 mets treated in the autumn. So a total of 59 metastases. And what I'll point you towards is a couple of other pieces of information on the screen here, which is the total volume of disease. So compared to the patient we've just seen, the disease that we treated with Kris was very, very small. So each metastasis was very, very small, and the total volume of the 15 metastases treated that January was 1 cc. Likewise, in the summer, despite there being 23 mets, the total volume was only 0.7 cc's. And similarly, in the autumn, 0.5 cc's total volume for 21 very, very small metastases. And this is really where the gamma knife performs very well, is in treating these multiple small lesions. And for those of you who are clinical oncologists or radiation oncologists, I've put down a couple of the other metrics that may be of interest to you. And particularly, I think the mean dose to the brain. So the idea of Kris wanting to avoid whole brain radiotherapy and have some more focused treatment, what we're able to do with our highly conformal gamma knife treatments is actually really restrict the dose of radiation outside our target. So each time the treatment was given, the mean dose to the brain as a whole organ, if you like, was between 1 and 2 gray, which really does leave options open later for retreatments or for other radiotherapy treatments to be offered. Okay, so I'm going to move on to the last group. So we've had multiple relatively large metastases. We've had a great example of multiple very small metastases. But then there's another group that Mr. Kitchen also mentioned where we offer staged gamma knife treatment. And rather than having treatment at one sitting, patients with either very large tumours or tumours in a very difficult location or concerning location, or tumours with a large amount of edema around them that we're concerned may be the patients may become unwell with a single large radiotherapy treatment. We offer them this stage treatment whereby they have 3 treatments with 2 weeks between each one. So essentially they have a single 10 gray radiotherapy treatment on the Gamma Knife, and then 2 weeks later come back and have their second, and 2 weeks after that come back and have their third. And what we often see with this stage treatment is a reduction in size of the target during that 4-week interval, or 2 weeks and then another 2 weeks. And that allows us to adapt the treatment so that the size of the target initially on the left here at fraction 1 of 10.1 cc's outlined with the blue contour, by the time we reach the third treatment has significantly reduced in overall volume to the point of the yellow contour, to the size of the yellow contour here. And that happens incrementally. And what that therefore means is that we're able to deliver 3 separate Gamma Knife treatments to a shrinking target volume, and that significantly reduces the normal tissue dose around it and allows us essentially to adapt to the changes as they happen. And this is an example of another breast cancer patient who 6 weeks later at their post-Gamma Knife imaging has very little residual disease left compared to how things were when starting. The last case I've got is another example of staged Gamma Knife treatment, except this time the indication isn't so much the size of the lesion, but more the location. So you can see here that there's a cystic, necrotic, and peripherally enhancing lesion on the right-hand side of the pons for this patient. And these are the 3 Gamma Knife planning MRI scans performed at the first, second, and third treatments. And unlike the case I've just shown you, you can see actually in this case, there hasn't been a significant change in size or volume of our target, but we were able to safely deliver the Gamma Knife treatment over these 3 stages to this patient. And then later on, 6 weeks later, we do see a significant reduction in size of our target, and reduced peripheral enhancement and the reduction in size of the central cystic component of this tumor as well. So the cases I've tried to show you here are illustrating really what the capabilities of the Gamma Knife are, and we are keen to investigate particularly staged Gamma Knife for either solitary very large lesions or lesions that are in a particularly difficult or high risk site. So I think that concludes my talk. I think we'll all come back onto the stage now and try and answer some of the great questions you're bound to be posing.
Thanks very much, Michael. Great. So welcome back, Kris and Michael, to the stage, and got a lot of questions, so I'm going to just crack on till we have to stop at 7. So Kris, Daniel writes, thank you for sharing your journey. Could you explain how you found Gamma Knife treatment and how easy was it to get access to it in the end?
For me, it was a case of actually knowing someone, a consultant in London who happened to be working at the hospice that I used to visit, who I just emailed and said, do you know anyone? And she said, yes. And so I guess I got lucky that she happened to know Naomi First at UCLH, who I managed to get a referral to. And I went back to my oncologist and said, I need a referral to this person ASAP. And my notes were sent over, and that's how it went. Of course, it shouldn't necessarily be the patient that searches for these people or this kind of treatment, and it should be widely known that it's accessible on the NHS. And I guess that's why we do things like this, to make people more aware of it. But that's how I managed to get the treatment, and it was on the NHS, thankfully.
Thank you. Michael, Hassan writes, do you support with steroids during Gamma Knife treatment?
So that's a very good question. Lots of the patients we treat are placed onto dexamethasone when they present, assuming they're symptomatic of their disease. We often judge the requirement for dexamethasone based on the planning MRI scan on the day. And if we're concerned either that there's a fair amount of vasogenic edema around our targets, or we're concerned that we may trigger significant vasogenic edema, we will often start patients on dexamethasone or temporarily increase patients' dexamethasone dosing. Often it doesn't need to be for long, it can just be for a few days, unless there are particular concerns. But it is certainly something that we use to support the immediate side effects of Gamma Knife, which actually aren't too bad usually for our patients.
Yeah. And in fact, there's no reason why there should be any immediate side effects, really, because the radiation passes instantaneously through the patient. But we do know that some patients do feel, for example, nauseous with headaches and feel out of sorts for a few days afterwards, particularly when they've had long treatments, maybe due to the radiation, or maybe indirectly due to the as Kris eloquently put, spending hours in a Gamma Knife machine with a frame bolted to your head. So there's a combination of things, but I think it's fair to say we don't like to keep people on steroids unnecessarily in this situation, because it may well be at certain parts in their patient journey they're going to need them more. Okay, thank you. Now, there's been a lot of questions about volume of disease, which is interesting. A lot of questions. And Girish has written, is the volume of 20 cc's or less for a single lesion or multiple lesions together? Well, it could be either. And actually, 20 cc's is quite a large volume. When NHS, it's a bit parochial, this, but when NHS England originally decided to organise a network in England and describe the criteria for treatment sponsored by the NHS, they were initially going to put the number of metastases as a limit. But we and other clinicians appealed against that and said we didn't think that was correct, and there should be a volume cutoff. And I'm not quite sure how they chose 20 cc's, but it is a large volume, and that gives us a lot of scope, really, to treat appropriate patients, thankfully. Okay, Kris, a couple of quick ones for you. Is your breast cancer hormonal?
Not anymore. It's done that thing where it's mutated into a less hormone sensitive cancer now, so it's deemed triple negative. And that was discovered from a biopsy. Okay.
And Daniel's written, thank you for sharing your journey, Kris. Could you explain how you found the Gamma Knife treatment and how, we've had that one, but how you found the Gamma Knife treatment, i.e. the experience of it? And in particular, just quickly mention the difference between that you found, at any rate, between the mask and the frame, please.
Personally, I prefer the mask because you don't obviously have to have it bolted to your head, but the frame has to be bolted. And I believe there was a question about anesthetic and why that's used.
Yes.
And in my case, it was used to numb the area of my head where the bolt had to go in. And without that, that would have been significantly more painful than it already was. So these 4 bits need to be bolted in there. So personally, I was very, very glad that in the 3rd treatment, I was able to use the mask instead.
Yeah. I think most people like the mask. I think there are circumstances where we can't use it, and Michael will be able to comment. For LINAC-based fractionated therapy, the time in the mask is much shorter. Could be only 5 minutes or something, Michael, couldn't it? And so we're talking here a longer period of time. And I think we had the occasional patient who are not compliant for whatever reason, and in that case, the Gamma Knife stops the treatment if there's too much movement, and then we have to start again. So the actual reliability of the time it takes to treat is less with the mask. Michael, do you want to make any comment?
Yeah, I agree. I think the frame is much harder for the patients, or for some of the patients, because of its invasive nature, and some of our patients are very keen for the non-invasive thermoplastic mask. But as you say, Neil, it does lead to potentially more movement, and the tracking within the room can lead to the treatment stopping, and the stop and start nature of that can extend the overall time, which kind of becomes a little counterproductive. If someone's struggling a little bit with the time in the mask, they actually end up perhaps being in there longer than is absolutely necessary. So I think it's, it's good to have both options, I think, for patients, and to counsel them and explain the differences between the two, because I think at first glance, the idea of having the invasive frame doesn't sound particularly good in comparison to something that's non-invasive. But I think there are pros and cons to both, and I think it's about offering them to patients and making sure they make an informed decision, as with everything.
Yeah. Thank you. I don't think the new frame, the Vantage frame I showed, is going to be necessarily any less uncomfortable, but it does offer a significant advantages in terms of image accuracy, we feel, and resolution. And about anesthesia, yes, everybody with the frame gets local anesthesia. We do occasionally treat adult patients under general anesthetic, but only if they are claustrophobic and can't have an MRI scan really, and there are some patients who can't. And also children, we treat all our children under general anesthetic. Dan asks, Kris, has the local hospital learned from your experience and now offers treatment for more than 10 mets?
I don't know about the Devon hospital, but my hospital is still only able to offer whole brain radiotherapy for multiple brain lesions, but that's because they don't have the machinery to do it. But I believe that my oncologist has now been sending more people to London like I was, knowing that that's a very doable and easy pathway to this kind of treatment. Yeah,
I mean, I think the network that was set up now 6 years ago means there is a network of centres. Not all of them have gamma knives, but we now collaborate very nicely with the centres who, particularly with those patients with a number of very, very small, what we call micromets, are better treated on the gamma knife. It's quicker and more reliably accurate, and there are cross referrals from the other centres to us. We're very happy to help, obviously. Now, this is a combined question. Amazing patient story, a real example of treating volume rather than numbers. But then it says brain scans are usually not a routine part of follow-up in cancer patients. And I think that you brought us up, Kris, in your talk. So perhaps Michael, I mean, as a neurosurgeon, I'm always amazed that in cancer patients, the ongoing screening seems to stop at the neck. Why is this?
So I think that's a very good question. And I have to say, I think things are changing as time goes by. I think there are certain primary cancers where routine brain staging at diagnosis and then routine brain surveillance as part of post-treatment follow-up is undertaken. And I think perhaps, it goes back to a historical view, perhaps of a bit of nihilism around brain metastases and the fact that historically patients with brain metastases didn't do very well, and therefore, if treatment options weren't particularly available, then it's not worth finding out, which is clearly no longer the case at all. And I think there has been a move to be far more proactive at investigating patients, certainly with symptoms, but I think the issue here is patients without symptoms and being able to identify asymptomatic early metastatic brain disease and being able to step in. And I think Kris's example is a really important one of the importance of doing that. We won't get too technical about it, but there'll be certain stages of primary cancers where having your brain scanned is thought to be routine, and certain stages of primary cancers where it's less so. And it's thought, it relates to the risk. So the more advanced that someone's primary cancer is, the more likely they are to have metastatic disease anywhere else. But I think there is a move across oncology to just better identify the full extent of the disease that a patient has, so that we can come up with the best treatment strategy for them.
Thank you. Okay, so we've got a question and a comment really from a registrant from Kenya. I'll read it out. Coming from Kenya, there are no centres offering gamma knife radiosurgery, so sometimes we perform metastatectomy, i.e. surgical removal of the metastasis, especially if accessible. Otherwise, the patient is sent for whole brain radiotherapy. Currently, we have a 50-year-old lady with a metastatic nasopharyngeal carcinoma to the posterior fossa. She presented with a GAS score of 9. I don't know what that means. Her CT scan showed a large lesion with significant perilesional edema and obstructive hydrocephalus. We inserted a VP shunt. How would you approach this? Well, I think so. Thank you very much for contributing that. So sort of a general comment really about the interplay between surgery and focused radiation in the form of gamma knife. The thing about gamma knife is it can't reduce the although it works in a few weeks, it doesn't work in a few hours. So in particular, if there is a large single metastasis causing cerebral edema, usually or often the best treatment is to remove it, because that gets the patient out of the particular corner they're in and then allows us all to regroup and decide what's the best next treatment for them. And it may well be that in the UK, we would do exactly what you've been doing in Kenya for that particular patient. Having said that, there is a high local recurrence rate with neurosurgical excision of metastases, probably in the region of 25 to 33%, so very high. And so it's not, it's not perfect by any means, and also in addition has risk to it. We are, and not all centres do this, but we are endeavouring to reduce that local recurrence risk in our unit by giving what we call cavity radiation with the gamma knife, or if too large on our LINAC based system, to try and treat the surrounding area to reduce that risk. And we'll have to see how that pans out in due course. It's very, very well tolerated by patients, I would say. And so you can do it kind of both ways. You can say, well, we'll have to do an operation and then give gamma knife, or you can give gamma knife and then if it doesn't work, have an operation. But what our experience has been, as you saw the graph I showed, 95% very good local control rate means if we get the patient selection right, it's pretty unusual for a gamma knife case in this situation to require subsequent surgery. There was an associated question really for Michael to answer, and which kind of goes with this a bit, from Jose Manuel. Do you use margins in brain metastases? Which I think is a very good question.
So I think that's a very good question. Yeah. I also saw there was I'll associate another question I saw, which was about astrocytomas and the role of gamma knife in treating those.
Yeah.
And I think the biology and the behavior of brain metastasis and the way that they're thought and understood to grow inside the brain is slightly different to primary brain tumors. So the idea that a metastasis seeds and then grows and it kind of pushes out the surrounding normal brain tissue and doesn't show significant infiltration throughout the brain and a kind of along the white matter tracts that we see in primary brain tumors. So the astrocytomas, I saw a question on that. So we tend to put quite large margins around primary brain tumors because of their infiltrative nature. But actually for our stereotactic treatments and the gamma knife treatments, we don't put margins on. We treat to a very high stereotactic dose, and the dose falls off very steeply outside our target. But actually putting a margin or significant margin around it, or a large margin around it, will increase the risk of toxicity by treating healthy brain tissue to a very high dose of radiation, and doesn't lead to an improvement in local control. As Mr. Kitchens explained, 95% local control treating without margins is a pretty good strong argument for saying actually we don't want to treat more tissue than that.
Thank you, Michael. There's a question about with the 20 cc max volume for each treatment, or was it a total lifetime volume? Well, I think what we mean by that is it applies to each gamma knife treatment session, be it in 1 or 2 sessions. But the registrant does comment about, or were only 20 odd lesions treated at a time. And so I think what they're saying is, do we have a cutoff, a time? It's not really the number of meds, it's the time cutoff, because I think Kris will, has told us that she was in the Gamma Knife machine for several hours, and even for someone as young and fit and healthy as she is, she found that quite a trial. And the problem is that, and it comes to allude to another point someone else made about how can they as a patient know what the total volume of brain mets are. Well, you can't on a normal diagnostic MRI scan. You can only guess, and indeed the referring doctors can only really guess. But when we look at the referring doctors' scans, we've seen so many, we can tell roughly how much the volume is. But often what happens is we make a plan for treatment, but based on the referring scan. And quite often, by the time the patients come for Gamma Knife, and we try to treat everybody within 2 weeks of our MDT meeting, but even so, the scan that the patient has a higher resolution, thinner slices. We give a double dose of contrast medium. So we quite often in this circumstance discover more brain metastases than was on the diagnostic scan. And so that means that treatments become longer. And we do try to treat everybody on the day, but that can mean a several-hour treatment. And I know some colleagues, I spoke to one last week who works in the Gamma Knife in Hamburg, says he tells the patient that if the treatment's going to be over 4 hours, they will stop on that day and come back another day to treat the rest. So everyone knows where they stand, and it's better for patient work through for the Gamma Knife unit. I don't think there's any rights or wrongs, actually. And it becomes more of an issue if you have many. I know, Michael, you said there's these 3 situations which you describe, but sometimes you have one big metastases and you have other small ones which can be treated in one dose. And then that also becomes tricky, because if the patient comes back for their second or third stage of the larger metastases and people see other ones, it can complicate matters, can't it? I mean, I would say that long are the days. Sorry, Mike. I say that long are the days that we suggest a one-off treatment. We bring patients back now several times over weeks and indeed months for treatments as we consider appropriate for the patient. Okay. Let me see if there's any other. I think we've got time for a couple more questions. Another one from Kenya, for Michael. How does whole brain radiation with hippocampal sparing compare with Gamma Knife therapy in terms of overall survival?
So that's a very good question, Peter. They are very different techniques. So whole brain radiotherapy is clearly not a focal treatment. It's purposefully treating the whole of the brain. Hippocampal sparing is a technique that's trying to reduce the neurocognitive toxicity of it. So trying to reduce the memory impact and the other impacts that Kris was concerned about when it was offered to her. So there's 2 things to say. Number one is that it delivers a significantly lower radiation dose to the actual targets themselves compared with Gamma Knife, which gives much higher doses. And it would be used, certainly in our practice in London, it would be used in different patient groups. So patients who were not suitable for Gamma Knife or not suitable for focal treatment could be offered whole brain radiotherapy. The hippocampal sparing basically hollows out the hippocampi within the brain to get much less dose than the rest of the brain, which technically is quite complicated in terms of radiotherapy planning in comparison with standard whole brain treatment. And certainly some patients can have disease in or close to their hippocampi, which would make you not want to offer hippocampal sparing in that group. So I think in terms of overall survival, we wouldn't put the 2 groups together, certainly in our practice. Those who could be offered focal treatment with Gamma Knife would be best treated with that, and we would expect their survival to be better as a result.
Thank you. Now, we've got a whole lot of questions flooding in, which we can't answer, but we will try to do so at a later date. So I go back to Kris, actually, and it's about this. This is obviously caused some interest, Kris. Someone, again, has asked, has your cancer changed from hormone to negative at any point? And if so, why?
Yes, I said before, it has switched to triple negative. Why? I don't know. Cancer is very clever. I guess, I mean, I have been through all the hormone sensitive treatments anyway, this hormone treatments. So it wasn't working anyway. So now I'm only being able to offer, they're only able to offer me triple negative treatments. So that means HER2 negative, ER negative, and progesterone negative treatments.
Okay, thank you very much. So, well, we've come to the end of the hour, everybody, and there's a whole bunch of questions we haven't been able to answer, but we'll get back to those in due course. A member of the team will. And we'd like to thank you all very much for attending. There's been over 160 attendees, so thank you very much, and thank you for being so interactive. As I said in my final slide, it's a multidisciplinary team that manages metastatic brain tumours, and the most important person in that team is the patient, of course, because it's what they want is what we will endeavour to give them. So, Kris, in particular, thank you so much for spending an hour with us, telling us your personal story. Michael, thank you very much indeed for your time too. And good night, everybody, and have a good evening. Bye for now.
Thank you.
Bye.